Thank you everyone for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is Set Up Your Practice for a Successful 2014 Meaningful Use Attestation. We're joined today by Joy Rios of Format Approved. Joy is an expert in both meaningful use and EHR proficiency with years of real-world experience in meaningful use attestation and EHR implementation and optimization. Joy has a unique talent for taking difficult material such as meaningful use and explaining it in straightforward terms. Before we begin, a few quick notes. Remember that you can ask questions of Joy at any time during today's session by entering them into the chat area. In the second half of our session, we'll address as many questions as time allows. If we run out of time, answers to those questions will be posted to our website and sent via email link later in the week. Also remember that all registered attendees of today's session, whether they attend or not, will receive an email with links to both the slides and the recorded version of this event. So if you're looking for the slides that we're going to see here today, we will send them to you following the event. So first of all, Joy, thank you for joining us.
My pleasure. As always, I'm happy to be here.
It's always a pleasure to have you. So let's dive in. It seems like, or it seemed like this day would never come, but here we are, 2014. But let's start with what practices need to do to attest for 2013. So what should they do now?
Okay, so as a reminder, the attestation part, this is the piece of the process of the EHR incentive program where the providers are approving or essentially attesting that they're meaningfully using their certified EHR. So this can happen through Medicare or through the Medicaid programs, and it would happen through the CMS website. So if it's Medicare, there's an attestation and registration website where if you haven't registered yet, you have until February 28th to do so, and then you also have until that deadline to attest to all of the use of your EHR technology. Medicaid, the state programs have sometimes different requirements, so definitely providers should be paying attention if they're attesting through Medicaid to make sure that they know what those requirements are and they know how to meet them. So if you're a provider and you've gone through all the process of implementing EHR and changing your practices and meeting the meaningful use guidelines, if you don't actually attest to them, then you won't receive any of that incentive money that's available for all the hard work that you've done. So the numbers are in. So we're looking at whether you're in year 1, stage 1, or year 2 of stage 1 for 2013. That would have been a 90-day reporting period, or the full year. All those numbers for each individual provider would be available through either the meaningful use dashboard of your EHR, or a combination of different certified EHR technologies that needed to be collected, put together in an organized way, and then you need to go on to those either Medicare, the CMS, or the Medicaid websites to input that information.
Now, Joy, we usually save the questions for the end, but this one's timely. Is that February 28th deadline applicable to both Medicare and Medicaid?
That's correct. Yes.
All right. Okay, so how can practices then create a model to get ready for this 2014 reporting year?
Well, there's a lot to do. As you know, we've talked about it many times in the past already, that this year is a big year. There's a lot of change. So the first and probably foremost important things that providers can do is figure out if their EHR is certified for the 2014 edition. No matter what stage you're in, if it's stage 1, year 1, stage 2, year 1, any of it, you need to have the 2014 certification for your EHR in order to attest. So if you don't know if your EHR is certified, one, get in contact with them. A lot of them are in queue, so there's a huge mine and backup right now of vendors that are going through the process of certification. So if they're not certified now, they could very well easily be certified by springtime. So make sure that you get a statement from the vendor just that's secure so that you know what their timing is going to be, because that's going to affect your timing. Which brings us to the next one, is choosing a quarter. So for stage 2, folks need to report a 90-day reporting period that is aligned with a calendar year quarter. So January 1 to March 30th. Well, if your EHR, etc., if your EHR is not certified for 2014 and they're not going to be certified until March, then you're not going to be able to input or meaningfully use that EHR until after they're certified. So those two pieces kind of work together. And if you're in a position where your EHR is not, and they don't plan on being 2014 certified, well, then you would be in a situation where you would very seriously want to consider switching. And we're going to go over some of those topics of what you should consider if that applies to you in just a little bit. So basically, we're going to be managing a lot of change this year. So it's important to have a team just dedicated, to meaningful use. If it is a matter of just 1 or 2 people, if you have a larger staff, however many people, it's affecting everybody in an organization. So it's really important to make sure that you're addressing and defining who in the organization these meaningful use requirements are affecting, who has responsibilities to contribute, and making sure that everybody's working together. So certain things like collecting, demographic data or collecting patient emails, they typically will fall under the responsibilities of somebody at the front desk. It's really important to make sure that that person knows what they need to do, and so that they can, be accountable and contribute to that particular measure's success. And just as you become familiar with your meaningful use dashboard, like we talked about in the previous question, it's important to get familiar with your reporting module, because you're going to really need to be mining data and searching for patients with specific diagnoses or problems or genders or age. That really is going to tie into 2 specific measures. One is patient lists, and another is patient reminders. So keep in mind that patient list it's an interesting thing. So you may have generated a patient list for patients with a certain condition of a certain age or a certain sex, whatever, in your first year, but that list is not acceptable for the 2nd or 3rd year. So whatever lists you're generating have to be somewhat different. So it's good to have a plan and making sure that you know what it is you're looking for going into, and it would actually be really smart if you can tie those lists in with your clinical quality measures. So if you know ahead of time what your clinical quality measures are going to be, then you can start searching for the criteria that are included in the instructions of the CQM in order to meet multiple criteria for each different, for multiple measures. And speaking of clinical quality measures, this is the 2014 year, an additional change. I'm sure you've heard of it, but in the past it has been 3 clinical quality measures, 3 core plus 3 additional that were required, so a total of 6. 2014 and go on and on, no matter which stage you're in, their CMS is requiring a total of 9. So thankfully they have a recommended set, core set of 9 that covers all of the National Quality Forum strategic domains that have already been set aside and recommended. And if those don't work for your practice, then you can choose from a list of 64, so long as you make sure that those 9 cover 3 of those domains.
Now, I just want to step back for a second to emphasize this point, which is even if you're in stage 1, when you're in 2014, you've got to report on the 9 measures. It doesn't matter which stage you're in.
Exactly. So it's really, there's a lot of moving pieces, so I think it's important for folks to have a meaningful use team that meets on a regular basis, making sure that you're, monitoring your scores weekly, making sure that you're looking at the meaningful use dashboard by reporting period, by eligible provider, to be able to track and monitor the trends and changes in scores. If there's, if you see an area in your facility that is either not responding to certain meaningful use requirements, then you can, take that data, look at what negative impact it's having, and create an action plan for trying to improve it. And ideally, if you're really getting to the point that you're being proactive and knowing your stuff, making sure that you can build a compliance, it would be great if people had a compliance manual by role, so that they say, okay, here are my responsibilities, and this is how I can meet, the specific requirements, which is, it's pretty comprehensive and a big task, but that would certainly help practices create a model for success for this coming year.
Okay, so a lot of people are still in stage 1 this year. What do they need to do to get ready?
Well, so the stage 2 final rule affected a lot of the things first, not too many, but enough to pay attention to stage 1 changes. So one of them in particular is that there's 5 meaningful use menu objectives that need to be reported for stage 1 out of a total of 10. It used to be that you could just choose whichever of those 5 you wanted, but now they're making it so that if you can't prove that you're unable to meet one of the 5 you didn't choose, then you're not justified in choosing that exclusion. So you kind of have to prove that you're eligible to exclude the ones that you choose not to report on, not just cherry pick the ones that you like the best. I think that's a pretty good way of putting it. And then vital signs, there were some things that were they changed it in 2013 that it was optional for providers to report or to take vital signs for patients aged 3 and above. And this is actually a change that is a little bit easier on folks, because the previous standard was that you had to take vital signs for patients 2 years of age and older. So they've actually lightened up and said, okay, 3 years and older going here from 2014 and on. For the computerized order entry, they just made a slight change, and that's that you can, it's 100 orders or fewer that you can be excluded from it, and you need to be able to track the number of prescriptions that you write. So you can't just say, oh, I don't write 100 prescriptions. If you write anywhere between 99 or fewer, you need to keep track of how many you do write, because when you do exclude that particular objective, they're going to ask you for the number of prescriptions that you've prescribed during the reporting period. So it's not just as easy as saying, oh, I choose to exclude this one, or this one doesn't apply to me. There's some evidence-based requirements to this one in particular. And then next is the core objective number 6. This one is sort of changed from the from before the final rule, where 50% of the unique patients need to have access to their health information between 36 hours of discharge, and more than 5% of those patients must be able to access that information online. So this is where they need to be able to view that information, download that information, or transmit it to another facility or doctor place of care. So this is where the patient adoption of online access and being able, can really impact the practice's success in meeting meaningful use. So it's really important to start planning now to try to figure out how you're going to engage those patients. Is it through a personal health record, a PHR? Is it through a patient portal? And making sure that you're set up for success in that area. And then also, again, so with stage 1, it's those increase of the CQMs, where before you had 6, now you have 9 to report on.
All right, and then for those folks who are headed into stage 2, what do they need to do? And maybe first we should just address, for anyone who may still have this misunderstanding, stage 2 is not delayed. Some people thought that the final rule said, oh, stage 2 is going to be pushed back, but it's actually stage 3 that got pushed back. Maybe you could just speak to that, and then, yeah, go ahead.
Yeah, sure. So it's still starting. Stage 2 starts for as it was intended in 2014. It was supposed to go through 2016, so that stage 3 would start in 2017. And what they've extended is now stage 2 will last for 3 years and go through 2017, so that stage 3 will start in 2018. So we're hanging on to this particular change for a little bit longer before they change the rules again.
And then the other change is that the certifications, and correct me if I'm wrong here, the certifications of the EHRs have moved, instead of being tied to stages, they're tied to years. Is that correct?
That is correct, yeah. So they're calling it the 2014 Edition certification. And if you saw earlier the certified EHR technology before from CCHIT and the other ONC certifying bodies was related to the year. So it was 2011 certification. So that was the beginning of stage 1. Now we've got the beginning of stage 2 for 2014. And that's not necessarily tied to when the provider starts stage 1 or stage 2. It's just kind of when it was available. So I would anticipate or expect that we'll see a stage 2018 certification edition in the future, but we'll see.
All right, well, please continue then about stage 2.
Okay, sure. So almost all of the menu measures from stage 1 are now moving into stage 2 core set. So in this year, the requirements like incorporating structured lab results and sending summaries of care, those were menu objectives in stage 1 that now are requirements for stage 2. CPOE has opened up where it's not just tracking prescriptions in stage 2, we're now tracking lab orders and radiology orders. So what you'll need is to start connecting to your labs and imaging centers, potentially, more than a few, because the requirement is that you need to meet 55% of lab results need to be stored as structured data in your EHR for stage 2. And if you are connected with your imaging center, more than 10% of those imaging results must also be accessible through the EHR as structured data. So that means that you need to actually be able to read the results. If the results are in a range, like, or if they're positive or negative, you need to be able to see that as distinct data, not as included in a Word file, or not a Word file, but free text, where you can't really distinguish between different units of information. And again, so we're going to need to patients are going to need to access their health information electronically. So more than 50% of them are going to need to be able to view, download, or transmit their health record. And also, they're going to be able to need to do secure messaging. So this is an interesting one. It's where the patient initiates a secure message to the practice. And think about how that would happen. That would happen through a PHR or through a patient portal. And that means that in order to kind of continue with communication, open communication with the patients, it's going to be important to collect the email addresses of all the patients so that you can engage with them online and in that way. So another one is recording family history. So there's 20%, that's the threshold. All unique patients, you need to have captured information on a family member that shares 50% of the patient's history, DNA, etc. And then also with stage 2 that you need regular registry requirements. So it's not just, in stage 1 you just had to test whether you could successfully submit immunization data or syndromic surveillance data to a registry. and now it's ongoing submissions. So you're going to have to be able to prove that you've not only done it once, but have been able to do it on multiple successful attempts. So some are more challenging than others, which is what we'll get into next.
So what are some of the more challenging measures to meet?
So the transitions of care, I feel like this one is a big one because it requires a lot of coordination. There's a lot of moving parts on this one. This is where you need to provide for more than 50% of transitions of care and referrals a summary of care. So in order to do that, they have specific requirements. One is that more than 10% must be completed either electronically using the EHR technology or via the National Health Information Network Exchange participant, and so the NWHIN, and also to be able to conduct that transition of care with a vendor using, or with a provider using another EHR vendor. So they have test EHR vendors on the CMS website, where if you want to test if you can transfer, because there's plenty of providers within that are using the same EHR that you can easily send over a patient record, but you need to be able to create the complete summary of care record in the specific format, which they've now updated it to the Consolidated Clinical Document Architecture, so CCDA format. And providers need to verify that they're following and making sure that they're including this particular information: the problem list, the medication allergy list, and the care plan. And leaving any of those particular fields blank within the EHR will not allow you to meet the objective. So there's making sure that the summary of care is complete and that it also can be transferred to a specific other type of provider or EHR vendor. And the secure messaging is one. It requires a little bit of extra setup and interfacing, because it's not, the secure messaging most likely will not come through the EHR itself. It would typically come through a patient portal or a PHR, and that's something that the patient would initiate, and then the conversations that can typically be had over secure messaging, they've given a little bit of guidance on that, and it's promoting healthcare coordination between visits, handling routine health issues, addressing patient questions or concerns, or monitoring patient conditions, or helping patients better understand their problems. So this could actually be a good place to address maybe some patient education, possibly. And it's also a place to handle just routine non-clinical tasks such as medication refills or referrals. So that's also counts as secure messaging. And then lastly, you'll hear this again and again, the view, download, and transmit. That one is a pretty challenging one. And I came across some information recently which I thought was really interesting, where there was a test that ONC did where it had to do with the number of patients seen during the reporting period and how many of those patients had actually logged in. And you would think that so if you've got a 90-day reporting period and you've got 350 patients that you saw during that period, and only 5 patients logged in to see their health information within that 90-day period, well, that would not meet the threshold, because that would be a pretty, less than 2%, and the threshold has to be at least 5% of patients log in to view, download, or transmit. But there's some results, and I'm not positive if it's going to work or not, but there has been some evidence that the reporting period could allow for patients who that the numerator can allow for patients that log in after the reporting period. So if you saw 350 patients within that 90 days, and it wasn't until a month after that reporting period is over, and say 25 patients logged in, then you could potentially meet that measure's requirements, even though the results for that particular enumerator are not within the reporting period. Does that make sense?
Well, it makes sense to me. It's a nice kind of grace period in a way to hit those numbers.
Yeah, so we'll see how that works. I've seen that in one place where there was O&C test data. That's what they suggested. So I'm hopeful that that is accurate, but we'll see. But again, folks, that's one of the it's one of the more challenging measures to meet because it has so many pieces involved in it.
So just to restate it, the idea here is that even if patients don't actually access that information and download it in the reporting period, that 90-day reporting period, they could, if they did it afterward, it would still count, is your understanding?
That's the idea. That's what some data has suggested. So we haven't seen that happen yet because there's been nobody's gone through the process, but we'll see. It is possible.
Now, of all of these, the secure messaging, we've heard a lot about that, and there's some concern about getting patients to engage in that way. But I think maybe the one that I've seen the most concern about, maybe the transition of care, and the concern seems to be that providers are going to have a hard time finding someone who can accept the transition, basically. Could you speak to that?
Well, that's why they should go, if that's a real concern, go through the NWHIN network, exchange network, and also you can look at the test EHR providers. So there are 3 EHR vendors that have been approved for receiving these transitions of care because it's really just testing the interoperability of it. So they are published on the CMS website, and I don't have the names of those 3 EHRs in front of me, but I will certainly gather them and give them to folks at the end of this, and also give people the information to that exchange participation network, because that is what will, they're giving people tools to help them. They know that these are challenging, and not everybody's going to have easy access to the answers, so they're providing people with, here's some tools to help you figure it out. Does that help?
Yeah, I think so. So which measures are excludable then?
Okay, so you've got the core set and menu set. Depending on the type of specialty and patient population, these are the ones that can be excluded. I won't go through all the details of each one, but it's things like if you write fewer than 100 prescriptions in the reporting period, then you can be excluded by the e-prescribe. If taking vitals is not relevant to the scope of your practice, then you can exclude yourself from that. So, for example, dentists, I feel like, fall into that category that they would be able to exclude vitals. People that don't have patients that are younger than the age of 13 can be excluded from the smoking status, core, objective. And if somebody doesn't have, if a provider doesn't have any office visits, they can be excluded from the clinical summaries. And it goes down the line with the menu set. So if you don't transfer any patients to other cares of settings, then you would be able to opt out or exclude yourself from the summary of care. If you don't give immunizations, or if the registry in your state or region is not set up to be able to accept your submission, your immunization submission, then you can be excluded from that as well. Same with a syndromic. So, but for those 2 pieces in particular, you cannot exclude both of them because those are population or public health measures. You have to report on either the immunization registry or the syndromic surveillance. You can't exclude yourself from both.
So how can eligible professionals know that they're doing it right? How can they sort of check up on their results?
Well, this is where you get to know your EHR, for one, really, really well. So one, continually be checking your meaningful use dashboard, and you'll start to notice they should give you results with the numerator, the denominator, and the percentage, so that way you can see exactly who in your patient population is eligible for each measure and how many of those that you have, taken the clinical action that's required in order to meet it. And you will start to notice that, how it changes on a weekly basis. You may find that you're doing well in, the majority of them, but there's one or two that you're not meeting the requirements, and that's where you focus your attention on. It really, taking the guesswork out, that's how you do it. Making sure that, data is your friend. Because that will help inform what your team is responding to. What areas do you need help with, or do you need to focus more attention on? CMS has provided a meaningful use calculator where you can test to see how, do pretty much a practice attestation. So it's not official. You don't need to enter in your NPI number. You can go in through objective by objective and see where, what your results would be. And they'll tell you, if you're successful or if you're failing. However, that is only available, they only have that for stage 1. I'm hopeful that within the next, quarter or so they will publish something similar for stage 2, but they have yet to do so. And if it's something that maybe is a little overwhelming for your team, don't be afraid to engage project managers. There's a lot of health IT consultants out there that, it's their job to make sure that their clients get their meaningful use dollars, keep their meaningful use dollars. They can help build those compliance manuals that I mentioned earlier, where they can help train, each individual measure for attestation specific to the type of practice, specific to the role, and they could help, recommend CQMs, and, really just kind of be somebody to lean on. I would highly, these practices have enough stuff on their plate right now. To get help is probably a good idea.
So let's address this issue of how can providers handle information from multiple technologies?
Yeah, this is an interesting one because you've got your certified EHR, that it's your EHR, right? But then anything that interfaces with it also needs to be certified. So there, again, is your patient portal. I don't think that the practice management or billing in particular, portion needs to be certified. But there are those labs and imaging systems, if they're pushing or pulling information, those have specific type of those count and can count as certified EHR technologies. There's also other vendors that just specifically will track the quality measures. Those need to be certified as well. So it's really important to know, one, take an inventory of which vendors are you working with, what are the technologies that are working together that are building and generating all your meaningful use information, and tracking down, making sure that they're certified. So there's the Health IT certification product list where you can search and see where if they have full complete certification, or if the vendor has modular certification, and be aware that there's different types of certification. So some will only push information where they're just generating and transmitting information, and then others have additional where they can also receive information too. So you would think that those would typically be the e-prescribing or labs where they're if they're pushing information into your EHR, they may just be generate and transmit as possible. But one thing to keep in mind, if you have a vendor or EHR technology that is not certified to the level that you think that you would like it to be, a lot of times the certifications, these vendors can run into problems because in order for them to get the EHR certification, they may need to include features and functionality into their product that's beyond the scope of what they actually provide. So you may run up into that. Just be aware. And it should be okay, but definitely it's important to just have an understanding of who it is you're working with, where they stand with certification, and then making sure that, all of the data and information in all of them is being collected in a way that will allow you to get accurate numbers.
So there's a lot of switching of EHRs going on these days. What should providers who switch EHRs keep in mind?
There's a lot. So this is actually a great year for switching. This is essentially the one-time opportunity that providers are going to have to report, if they're in year 2 or year 3 of meaningful use, you kind of get the lucky opportunity that this year you only have to report for 90 days rather than the entire year. So it's, you can leverage that. EHR switchers can leverage that timing and benefit from a lower compliance, bar while, while you're dealing with the different, all of the changes. So if you are switching, make sure that you are stitching together meaningful use data from the old and the new one. You got to make sure that it might actually be a good idea to overperform in your meaningful use measures in the old EHR. So, really do a push to try to get your thresholds and percentages up to as high as possible in the old one, so that as you anticipate, learning and switching over to the new one, that you can still meet the minimum requirements for meeting meaningful use. Consider doing a rollout plan so that you can phase it across, depending on the size of your practice. If you want to, just phase it into one specialty at a time, one location at a time, or one subgroup at a time. That can help, kind of lower the learning curve a little bit, so that people can, get time to get to know it, and then as the phases go through, then you have folks that already kind of know what they're doing and can help others learn. And then essentially plan to be supporting both of them at the same time. It's going to, it's not just an easy switch over from from phasing out one and phasing in a new one. It's not going to be a direct on-off switch. So you will certainly be working in both for a little while. So that's why it's going to take a lot of coordination, forethought, planning, being really strategic about, even the timing. So, once you guys find out where your EHR stands as far as their certification, and if you do need to switch, I would get that process started as soon as possible so that you can get your quarter aligned so that you can meet that whatever 90-day period you choose, whether it be the second, third, or fourth quarter of the year.
Well, this is another area where it might benefit practices to work with a consultant who has expertise in taking that data and getting it out of the old EHR into the new EHR in a way that's actually useful. We've had other sessions where we've spoken with experts on this, and there's a lot of different options for doing it, but doing it on your own may not be easy.
Absolutely true. And depending on the type of old EHR you have, you may find that some of the information that is trying to be extracted it's not apples to apples. So what you would be exporting from one system can't directly go in and be imported into the new one. So it's important to start thinking, okay, well, where are there matches, or what is the most important information to pull from the old EHR, and maybe you just start with that, and there could be some manual labor, data entry stuff for things that are not captured as structured data in the old system.
Yeah. Above all else, don't assume that the data is going to be easily importable into the new system, because that is a very dangerous assumption.
Exactly.
All right. So here we get to the kind of what's the worst that can happen. There's a lot of auditing going on of meaningful use. I think the report was that they hit nearly 6% last year. I believe their goal is 10% of attestations will be audited. So it's a real concern that people should have. How can they get ready so that if they are audited, they're able to pass?
Okay, great question, and very, very important. So boils down to, your obligations for participating in this program. You can certainly be, like you're saying, you can certainly be audited. When you sign off on each measure and attest it, you need to be comfortable that the work that's been done is, complete, audit proof, and, if it were to be looked over, that you would feel comfortable having multiple sets of eyes on that information. Keep in mind that documentation should be kept for 6 years. They can come back and look at that much information. So especially if you're in a position that you're switching EHRs, make sure that you're keeping all the information from the old system as backup. So the things that need to be kept, things like numerators and denominators for every single measure that requires them, keep records of that. The time period that the report covers, that's kind of an obvious one, but also whatever the exclusions are, claimed, make sure that you're documenting the reason why that they are claimed. Because if you just say, oh, this exclusion applies to me, but don't have any backup information for it, that can be a red flag for auditors. And then also the proof that functionality is available and enabled. So this is stuff like the clinical decision support system, interaction checks, drug formulary checks. Those are some of those alerts and warnings that show up when you're doing certain functions within the EHR. There have been some providers that, it's annoying to them, so they turn it off. They turn off that functionality. You need to be able to prove that that functionality is, one, included in the EHR, it's turned on and active during that reporting period. So you can't just, turn it off at your convenience. So one way to do that is screenshots. Make sure that you're getting, capture screenshots of maybe the admin panel on a certain date or something that shows on your computer screen that it is enabled at a certain time on at a certain date. That's one way. And then also screenshots of your EHR system when you're exchanging clinical information. So if you are exchanging a summary of care to another provider or somebody in that in the network or one of those test EHR vendors, grab screenshots of that stuff. And even better, if you could get a letter from the receiving provider that confirms that they received the exchange, and make sure that they include the specific information that was included in the exchange with the date, the name of all providers involved, and whether or not that it was a successful attempt to exchange information. That is a useful thing to have in hand. And the same goes for submission to the immunization registries or any public health agencies as well. So if you can get screenshots of your system, when you're submitting that information, or a letter from the registry or public health agency saying that they've received it, that would be extremely useful as well. And also important, make sure that you've got your proof of the security risk analysis for HIPAA. Make sure that you've got, a date of when that actually took place, with potentially, contact information, who's the one that created that, and always make sure that you have your business associates agreements in place with all third-party vendors and anybody who has access to patient information.
Yes, what we've heard is that the security risk analysis is probably the main way that people get tripped up on the audit. There's a lot of misconceptions that the EHR sort of is self-compliant in some way. I don't know why people imagine that would be the case, since it's, that the EHR vendor will take care of everything, since that is so rarely the case. But it's certainly something that people need to take care of, both to satisfy meaningful use, but also HIPAA. So that's a big one. The other thing we've heard is that, some of the audits are random, but a lot of them get flagged because the numerators and denominators are the data entered for those is basically impossible. So, for instance, we've heard that numerators are the same across the measures, which doesn't make any sense. And those are automatically going to be flagged. I mean, that's very easy for an automated system to catch.
Right. That makes a lot of sense. And also, they're doing the pre-payment audits and also post-payment audits. So it's possible that, before you ever see any meaningful use incentive money, that they'll come audit the information before releasing the check. I think that that's that 10% that you're talking about, that they're trying to get, that information audited before they release the money, because after they release the money, if they come back and audit it, then you would actually be responsible for returning it if you don't pass. And for some practices or larger organizations, it's a lot of money.
All right, so here we have, you always include helpful resources. Maybe you could just quickly run down what these are, and then we'll leave this up for people to look at as we go through some of the questions and answers. And of course, we have had a couple of questions about the slides. If you missed it earlier, we will send out the slides to everyone who registered for this event in our follow-up email. So you'll definitely have a chance to look at them. But Joy, just quickly run through what we've got here.
Sure. The first one, the register and attest, so that's where you've got the February 28th, 2014 deadline. So that's one of the most important sources there. So if you haven't registered yet for the EHR program, that is where you would do it, and each individual eligible professional needs to do so. That's also where you would attest for the Medicare portion. It is not, and on that website there is a link to the state Medicaid. So if you are participating in Medicaid, you can access your state's, attestation system by clicking on that top link. The CQM recommended core set, I included the recommended core set for the adults and also the full set. They also have a recommended core set for children or pediatricians as well. But that core set is, if you choose to follow that, it meets all of the requirements of the CQM. You don't have to do much thinking other than, following the instructions for those 9 that they have laid out. But if those 9 don't apply to your practice, then I would look at the full set and see a different measure that can be applied. The registry contact information, I included that because I just feel like that's sort of a nebulous information of where do you get that information to submit to your, the immunization stuff or any public health, that you get that information from the CDC website. I've also included that meaningful use calculator for stage 1. I was searching high and low for one for stage 2, but it does not exist yet. And then lastly, that EHR certification list. So if you're looking to see if your EHR vendor is 2014 edition certified, if you're looking for a modular certification or where they stand, that is the website where you can research and essentially start that conversation of understanding where all of your vendors stand currently in their process. Now, I can always give more resources. I feel like they can have a long list, but I think that that's a pretty good handful to get people going for this year.
All right, well, we've got a lot of questions, so let's get into them and see what we can get through here. And again, if we do, well, we're going to run out of time, so if we don't get to your question, look for that follow-up email where Joy will address it in writing. So quick question about nurse practitioners. This is about the state of California, but I think it's pretty universal. Are nurse practitioners eligible professionals in essence?
If anyone with an NPI number, so if you have an NPI number, then yes. But it's a matter of, you can go online and see the requirements where they really break it down. I believe that, yeah, if you have an NPI number, you're eligible. Let me double check.
And that's generally how CMS handles these things, is by the NPI number. All right, well, you're looking into that, Joy. There's questions about Medicaid. Some folks said that they thought, for instance, that people had until the end of March. The other is that some folks think that and we're talking about the reporting deadlines here, that some other folks have said, well, isn't it state by state?
Yeah, it is. So that's the thing. It's not the same nationwide. It is state by state. So that's why, Medicaid can have additional requirements for one state that's not applicable to the next. I try to stay away from talking too much about, then you go through the process of talking about, 49 or 50 different sets of requirements.
Right.
But yeah, definitely check with your state, because they may have completely different rules than, the neighboring one. So California, the Medicaid system is different from the Medicare, in that you can only submit information from the previous year. So if it were August 2013 and I wanted to submit, a test for a doctor who had their year one 90-day last year in the first quarter, I could have done that, last August. But in California, if it's Medicaid, then that you can't do it until January 1, 2014, because it has to be from the previous year. So I'm sure that there are a lot of anomalies for each state, that they have interesting rules and regulations.
So the upshot is, if you're participating in the Medicaid program, you need to really check your state requirements, and not assume that the national requirements are necessarily going to be the same as the states.
Exactly.
Now, someone's asked this. This is an easy one to address. For 2014, will any 90-day period do, or does it have to be a calendar quarter?
So it depends on what stage you're in. If you are in, well, also it depends on what year you're in. If you are in stage 1, year 1, you can choose any 90-day period. If you are in stage 1, year 2, or any year after that, stage 2, anyone that is not stage 1, year 1, can report a 90-day period, but it has to align with a calendar year quarter. So starting January 1, starting April 1, starting July 1, or October 1.
Now, I don't completely understand this question, but I think you might, and if not, we'll skip it and come back in the follow-up. But the question is, will the NQFs be on the domains for stage 1? It's kind of a little cryptic.
So I think that has to do with the CQMs,
right?
The domains, right? So no matter what stage you're in, you need to be applying the 2014 CQM rules. So everyone is is working off of the same set of requirements, and that is that yes, they need to be the 9 CQMs, and they need to cover, those 9 need to cover a total of 3 domains, no matter what stage you're in. Does that sound like that answers that question?
I'm not sure, but the answer, I guess, would be that you really need to look into the CQMs and the new requirements around them. Maybe we'll address that at greater length in the follow-up. Here's a great question I want to get to before and this is probably the last one, and then I want to share some information with people that I think will be useful. The last question for now: if we connect and send to a Health Information Exchange that's a NWHIN member, do we need a report back to show which CCDs have been received or read, or is just transmitting it enough? Can we include all the patients sent to the NWHIN?
That's a little bit technical. I think I would keep the information for all of them. But I guess would need to know what that actually looks like. So one, we're talking about keeping so it's the regular reporting, not just the ability to be able to submit and transfer this information. So I would say for as many times as you're transmitting, I would keep proof of that transmittal, if that makes sense. But I would also like to do a little bit more research on that to make sure that that's the correct answer.
Yes, for some of the complicated questions, it's always good to address them in writing. We are nearly out of time. I want to share some interesting resources for people here. First of all, I want to thank you, Joy, for joining us. It's always a great pleasure to have you here, and people really appreciate the information you're able to provide, so thank you.
Thank you. That's my pleasure, and I really enjoy these conversations, so I hope we get to do it again.
Well, we'll certainly have you back. And what I wanted to share with folks is Joy has regular columns that talk about these issues with us at Format Approved. If you look there on the bottom left of your screen, there's a link that you'll see in the slides, or you can go to Format Approved and click on the Content tab and look for Joy. The URL is www.formatapproved.com/HITanswers/author/JoyR. But you can just go on the site and find it or look at the link. Her column is called Ask Joy. It's very popular, so do check in and avail yourself of that free resource. The other resources I'd like to mention is if you're struggling with meaningful use, if you'd like to learn more about it, one of our most popular courses here at Format Approved is our Certified Meaningful Use Professional course, which we developed with Joy. And that course covers all of the requirements you need to understand for Stage 1 and Stage 2. It covers eligible professionals and the hospitals. It goes through all the CQM information you need to understand. It talks about HIPAA. So that is a great resource. That first URL on your screen there, Format Approved education/courses_cmup.html, will take you directly to that course where you can learn more about it and register. The education is completely online and self-paced. So if you register and purchase the course, you can begin as soon as you're ready. And then the second one is what I'm especially excited about. We've been working very hard on this with Joy to get a new course ready for PQRS, the Physician Quality Reporting System. This is a very forbidding program, to be honest. I can say that having worked with Joy on this course. And this course is going to be a great resource for people. We're very excited about it. It covers everything providers need to know to report for 2013. It provides guidance on setting up for 2014 and everything you need to know about how the program has changed. Learn how to maximize your incentive payments, avoid reimbursement penalties, and streamline your reporting. The course goes live on January 15th, but you can register today at that link. That's the second link there, formatapproved/education courses_cphp.html, to learn more about that course and pre-register. Again, that course will go live on January 15th. Really, you can find lots of resources on meaningful use and PQRS on CMS, but it's very hard to understand, really, to wrap your arms around it. And what these courses do is cut through that red tape and legalese and tell you what you need to do to succeed in these programs. So I think they're both great courses. Obviously, I'm biased, but go take a look at them and see what they include, because I think they can be very helpful for people. I'd like to thank all of our attendees. It's always great to have these sessions with you. Remember that all registered attendees will receive an email with links to both the slides and the video recording. So if you've appreciated what you've heard today, look for those and you can share them with your colleagues. Visit formatapproved.com to learn more about our upcoming Learning Lunches. The Learning Lunch button on the bottom of that screen of the home page there will take you to our upcoming webinars where you can learn more about them and register. Our next Learning Lunch will air January 14th and has the title HIPAA Happens, Understanding Data Safety and Patient Confidentiality. HIPAA certainly does happen. Keep an eye on your email box on our homepage for other upcoming topics, and thank you again for joining us today.